So Dr. Parveen Sen is there. She's going to tell us tricks for vitrectomy in diabetic TRD. Over to you.
Mike.
And have Dr. Shubhendu after this.
I'll take you to the vitrectomy for diabetic retinopathy. It is something which is so common that I'm sure each retina surgeon would have done it. So some tips and tricks which I use I can share with you. So TRD is the most common indication of vitrectomy, and I will stick to only that indication. It can be seen in almost 15% of patients with PDR, and with diabetic retinopathy being on increase, we are increasingly seeing it in our clinics. Pre-op assessment is vital, very important. OCT forms a very important part of it, especially if the media is clear. It will give you the extent of the membranes, it will give you the underlying architecture of the retina, how good it is, how much vision can improve, and how much is the urgency. Is it close to the fovea and would you need to intervene very quickly? Second decision, apart from, of course, the systemic problems that the patient is having and you deal with that, second decision is, do you need to give an anti-VEGF pre-surgery to this patient or not? And these are some situations where you would definitely want to give if there is extensive fibrovascular proliferation, or if you have a flat fibrovascular proliferation with no posterior vitreous detachment, and if you have obviously neovascularization in iris or angle. It helps in reducing the complexity of surgery, the vascularity of new vessel fronts, and intraoperative bleeding is reduced, and somehow I find it makes it easier to separate and find the correct plane. I often give this example to my students I say that wet notes, if you try to separate, they will definitely tear. But anti-VEGF, if you give it, kind of dries up the vitreous layer and the retina, and it is easier to separate without creating breaks. And but it has its own disadvantages. It can have a crunch phenomena where a TRD can extend onto a CRD very quickly, and timing of surgery. It should not be more than a week or 10 days when the crunch phenomena will be at its peak, and usually the ideal time is 3 to 7 days. So with that said, I'll just take you to a few case scenarios, and since the time is less, I will probably not play the whole video. I will just play the important salient features. So you can see here, the principles are that you go in, do a good vitrectomy all around, enter the cone somewhere, and then you make sure that you have cut the peripheral attachments. Once you are into the right plane, you can see that the fibrovascular prolif actually starts rolling into your cutter, and then I am a very ardent fan of the curved scissors, and with that curved scissors I use it as a forceps, as a pick, as everything, and once you keep on lifting it, you identify those pecks and then you cut. So I don't need to use any other instrument. Once in, I finish most of the surgery with the scissors and come out. So this is how you do it, and I feel with the scissors, once you are cutting only the pegs, the amount of bleeding that you get is also much lesser because you are not really cutting through the vessels. So this is how you are proceeding. You can turn the blade of the scissors. You see now I'm using it almost like a forceps or a spatula with my blades closed and nudging it slowly over to show me the so this is delamination. This is the technique which is taught to you first, and I am still from the old times. This is what I started with, and this is still my go-to technique in most of the cases. So this is in dense vitreous hemorrhage. So dense vitreous hemorrhage with underlying retinal detachment is something which you need to be very careful, because you don't know while you are cutting where the retina is lifted up, and you may end up cutting the retina to begin with. So you layer up the vitreous, and you can see this vitreous hemorrhage is all opaque. So you layer it till you are able to at least know that the underlying retina is attached here. And once you do that, you can see there is how much of TRD is there. If you go in blindly, you would have created a CRD, and cutting and cleaning a CRD is kind of more and more difficult. Again, the same thing, curved scissors to the rescue, and you can see that the retina is thin, and just because of the little drag, that itself can sometimes tear it. So you have to be very gentle. When you use your curved scissors as forceps, the best thing is if you put too much of pull, automatically it will leave, because the scissors is not a forceps. So this is that way adds to your safety. I only cut it when I see the pegs. So this is another way. Then there is another way of dense vitreous hemorrhage that you have. So This is another technique which I use very often, something I call the interface vitrectomy, that once you have dense vitreous hemorrhage, as you go on cutting, there is always a cloud of heme which keeps coming, and it kind of blocks your view. You don't know which way you are going. So temporarily at this point of time, you can see a lot of fresh heme is there. So temporarily at this time, when the smog starts coming, I put the fluid gas exchange on. And you can see once the fluid gas exchange is on, the principle is that the blood will only come into the fluid. It will mix only into the fluid. It will not mix in air. So your view gets better. You are able to pull up and suck all the blood which is there all around, so that this doesn't come and add to the cloud. So once you have done that, carefully picked up all the hemorrhage all around, now at this time, slowly you identify, you see now everything is clear, and now I'm only left with the fibrovascular polyp, and then I go back to my good old scissors, after, of course, putting the fluid back again and removing the air. Now I go back, my view is clearer, my job is more defined, and I'm not bothered by the blood at all. So this makes things easier, simpler, much more in control. So this is one technique. And this is another case of dense vitreous hemorrhage, which it was so dense that the hemorrhage was stuck on to the posterior capsule and no view. So I have used the chandelier to do the phacoemulsification here. This gives me a retroillumination. So these are some tricks that you use. Once you do a phacoemulsification with your chandelier inside, you are creating an artificial glow, and then you are able to, clear the lens. The lens is not so hard, but the thing is, because the capsule was fully dusted with vitreous hemorrhage, it had to go. You realize it, how dense the vitreous hemorrhage was once you have put the IOL, and then you see that I'm cutting the PC with the cutter. And this, now you realize how much it was blocking the view. So this is another technique, and again, just to quickly wrap up, you may have these kind of TRDs, large fibrovascular polyp from equator to equator. There is nothing but a polyp, and only game is here. You have to find a way to enter. That small blob of subhyaloid hemorrhage told me that here there is a separation between the posterior hyaloid and the retina. So I have entered here, I have made an opening with the MVR into that area, and once I enter here, I have got the plane. Now the story is good. You keep on entering slowly into this area. But because it is stuck, so I have to use forceps, I have to use the cutter and the scissors to make these inroads and slowly finish the surgery. So first, Nick, to identify where to enter was the most important thing here. So this is how, again, the whole surgery was finished. This is another one. This is a CRD, combined retinal detachment, where you don't have any posterior scaffold, nothing to hold back. So best is to go with the bimanual surgery to begin with, because the retina is all elevated and jumping. So you hold with the forceps and cut below it. You can see how mobile the retina is, and you have to do a bimanual surgery here. There is no choice.
Parveen, if you could wind up.
Yes, this is the last case. No PVD. Again, you do a bimanual surgery. In spite of all the care that you take, you may still have intraoperative bleeding, postoperative corneal edema, and so these things have to be taken care of. Most important is the recurrent vitreous hemorrhage, which has to be taken care of. And to conclude, with the advanced surgical planning and sophisticated procedures, we are still able to give good results to our patients.
I think exquisite videos with excellent, tips you gave us, all of us, We'll just take two questions, because I think...
So one is, I tend to do the same way, do a fluid exchange, but then I tend to use a little bit of PFCL so that I can do a dissection while no more bleeding occurs. I do not know how much of PFCL use, and I use a lot of proportionate reflux so that I can dissect out membranes. So what is your take on that?
You could do that. If you have cleared the posterior pole, then you can use a PFCL. But if you have to, usually for diabetic patients, we go from anterior to posterior. So actually speaking, your large polyp will still be posterior. In trauma, I use PFCL more often because you can use it to stabilize your posterior pole by injecting. But usually that area will be clear of fibrovascular polyp. But here, as you saw in this case, the whole polyp is there posteriorly. So sometimes the PFCL may actually come in your way of dissection.
At that time with the PFCL, you do a bimanual dissection. So
Yes,
it
you
actually
can do, but I'm usually able to, clear up and identify my pegs and finish. It's what you are more comfortable with, but generally I think PFCL works best when you have to work anteriorly rather than when you work posteriorly.
If you pick up the membrane from the disc, and all the membranes are not cleared, and if you get a bleed
Yes.
on the disc, what are the measures? What
So
you
vital
take,
thing is what you said already. First clear, rest everything else before you pick it up from the disc. Because there will be very little that you will be able to do. You can't cauterize on it. So then you other than increase IOP and reduce blood pressure, you can't do much. So best is, I initially used to, when we started, we were very happy to peel off the whole thing. Now I make sure I clean up everywhere, make sure there's no attachment to the fovea, and then cauterize it on the small, the stem or the peg onto the, cauterize it onto the disc. Try not to peel it off.
In this cases, sometimes when you dissect all the membranes also, there's a little bit of oozing from the disc.
Yes.
So do you prefer to give an anti-VEGF at the end of the
Yes, you can do that. Anti-VEGF at the end of surgery, a lot of us use. It can be done. It's very useful.
have you tried glue when it's in
I think
intractable bleeding?
Dr. Malika is here. She has described use of glue for these things. Even Dr. Tyagi is using it. So there's other things which can be used, but I have not used glue till now.
Thanks, Parveen. I think it was a very nice talk.